Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. In this Learn Shop, we're going to review part 4 of veno-venous ECMO, extracorporeal membrane oxygenation, and we're going to look at the ECMO circuit dynamics. Now what we're going to review are some of the equipment related to it. Cannula, the centrifugal pump, the artificial membrane, the gas exchanger, sometimes called the oxygenator, in the circuit. Now, when we look at the cannulas for VV ECMO or for VA ECMO, which we're not discussing in this Learn Shop, we have the single lumen. And the single lumen, traditionally, VV ECMO has been delivered by single lumen cannulas. And these are each independent cannulas at different venous insertion sites. Typically, it's the internal jugular vein and the femoral vein that's employed. Internal jugular vein and femoral vein. So what we see are two independent cannula, one taking blood out, deoxygenated, desaturated, and one returning. Now, we talk about arterial and we talk about venous, but there is no arterial. This is veno-venous. So the blood that is being taken out is desaturated, blue, and the blood being returned has been resaturated, oxygenated, CO2 removed, which is red. But there is no arterial. But sometimes we refer to it as arterial access and venous access. Here, on chest x-ray, you can see the internal jugular vein is the arterial return, and it's not really arterial, but it's reoxygenated. It's eucarbic, meaning that it has got normal carbon dioxide levels. The femoral vein is removing deoxygenated or hypercarbic blood. It is taking blood out. There are two cannulas. One situated in the superior vena cava or the internal jugular vein, and one situated in the inferior vena cava or the femoral vein. Then we have the bicaval dual lumen. And the bicaval dual lumen cannula has gained a lot of popularity with physicians and intensivists as a cannula for VV ECMO because you get simultaneous venous drainage and reinfusion of blood via just one cannula, the internal jugular vein typically. But the femoral vein can be used as well. It's preferable choice or situation on the patient condition. There we have the bicaval dual lumen situated in the internal jugular vein. There we have simultaneous venous removal, arterial return. But remember, there is no arterial. It's just reoxygenated, resaturated blood. On chest x-ray, you've got one cannula and you've got the venous return port, the arterial access port. Now when we look at the VV ECMO circuit components, we have the pump. And the pump, I've just chosen the cardio help because again, not for any other reason than this is the one I'm used to using. I did use and have used in my career, and I find it very, very user-friendly as a critical care pump. Okay? Perfusionists would be using a variety of different pumps. They would be familiar with all aspects of the VV ECMO and VA ECMO circuit components. But again, I've just chosen this one not to promote the pump here, but again, this is the one that I'm familiar with. But essentially, they all do the same thing, and they're all very user-friendly in these days. Now, the VV pump is used to oxygenate a patient's blood, also to remove carbon dioxide. And essentially what it does is give the lung a vacation, allows it to rest. It replaces the lungs. It's artificial lungs, really. And it replaces the lungs temporarily to provide an alternative method for gas exchange. Because the lungs, remember, are in an ARDS situation. Now, a component of the VV ECMO pump is also the oxygenator. So essentially what you have is one, you have the patient the ARDS patient. 2, the pump extracts blood out of the patient, pushes it towards the oxygenator, and then returns it resaturated to the patient. Now, when it comes to the veno-venous ECMO categories, you've got standard veno-venous ECMO, which involves the peripheral. Peripheral being the jugular, internal jugular, and the femoral vein as a cavo-atrial flow shunt. Here you can see again the catheters are located, 1 being in the internal jugular and 2 in the femoral vein. You can also have femoral cavo-atrial flow, which means you've got 2 femoral catheters in 2 femoral veins, the right and left. If we consider high flow veno-venous ECMO, what you're using are the jugular internal and the femoral right vein and the femoral left vein. And this is for situations where single lumen outflow is inadequate. You're not able to extract enough blood. Return's okay, but you're not getting enough out. You can also use double lumen V-V ECMO, where you're using the jugular as a peripheral, as we saw before, just 1 catheter, and this is for cavo-atrial flow, which is the more popular one these days. It's more user-friendly as well for the patient because they only have 1 cannula that requires insertion. So what you're seeing here is the 1 catheter. You've got the venous outflow, desaturated blood, and you've got the arterial, well again, resaturated blood return. Now, when we look at the basics with veno-venous ECMO, let's look at some of the functional physiology. Thanks, Elmo. Now, when we look at the functional physiology, this is how it works. We've got our ARDS patient that has been connected to veno-venous ECMO. Then we have the access and the return cannula, which in this situation will be 1 cannula in the internal jugular. Then we have the blood pump, and the blood pump creates a pressure, a negative pressure, to extract the blood. It's pulling it out, and this is a centrifugal pump. Then we have the access line where the blood is being extracted from. It creates a negative access pressure, and the SVO2 in most circuits is being measured. So the saturation of the venous oxygenated blood is being measured, and it will be low because it's desaturated blood. And this is sometimes referred to as the pre-saturation oxygenation level. Then the blood goes to the membrane oxygenator and a pressure is measured. A pre-transmembrane pressure, TMP, and a post-transmembrane pressure. And it's also connected to an oxygen sensor. And if either of these become either too high or too low, it will alarm, informing the person, the healthcare provider, the nurse, the perfusionist, the physician, if there's an issue. Then we have the return flow, and before the blood goes back to the patient, resaturated, reoxygenated, eucarbic, flow is sensed. And any air, there's an air detector as well, because we don't want to be putting air back into the patient. This will cause an air embolism. So there's a sensor. Now, there's also a sensor for the saturation of oxygenated blood. called the post-saturation oxygenated blood. And this is being measured because if we make a comparison between the SVO2 and the SaO2, we would expect, if the oxygenator were working, that the SaO2 would be higher than the SVO2. There's also a heat exchanger, because before we return the blood to the patient, we want it to be at a normal temperature for the patient. We don't want to make them hypothermic, and we certainly don't want to make them hyperthermic either. So the heat exchanger will essentially just warm the blood to the required setting that you want before it's returned to the patient. The blood is returned to the patient, resaturated, eucarbic, warmed to body temperature. Now, when we look at veno-venous ECMO and improving the SaO2, primarily what we're wanting to do is increase venous blood flow to the gas exchanger. Oxygenation relies on desaturated hemoglobin and contact with the membrane. Therefore, it's dependent on blood flow rate and hemoglobin. An adequate oxygenation in the VV ECMO circuit, typically we want it to be the SaO2 80 to 85%, which will hopefully give us a PaO2 of 50 to 55%. 50 to 55 millimeters of mercury. If any of you are not familiar with arterial blood gas analysis, go to the Dr. Manny Learn shop. It explains it fairly simply and fairly clearly on arterial blood gases. Now, when it comes to VV ECMO, it's V CO2 removal or removal of carbon dioxide. There's an increase in venous blood flow to the gas exchanger again, and CO2 removal relies on blood flow and oxygen flow membrane contact again. Therefore, it's dependent on blood inflow rate for the CO2 removal and fresh inflow of oxygen for gas exchange. This creates a diffusion gradient which occurs in your lungs at the alveolar capillary interface. Now, what are some of the flow determinants in relation to VV ECMO? Well, cannula size is important. The smaller the cannula, the less the flow, the less adequate the flow. Vein patency, you need a big vein, so you need a central vein. You need circulatory volume. The patient can't be hypovolemic. I mean, if they're in a shock state, it's not going to work effectively. The veins are going to collapse as a result of a suck-down effect when you're extracting the blood via your catheter. High intra-abdominal pressure can be an issue as well, because this will decrease venous return, which is reducing preload. And look, if the cannula is in the wrong place, then that's going to be a problem. So a displaced return cannula report can be an issue as well. Now, what are the causes of low saturation in VV ECMO? Recirculation can be one, having a high cardiac output, and of course, oxygenator malfunction. When we look at normal gas physiology for the VV ECMO circuit, we've got the saturation, which is pre-oxygenator. This is low. This is your SVO2. The ECMO circuit typically has a flow of around about 5 litres per minute. Then, after the blood leaves the diffuser or the oxygenator, the saturation post the oxygenator should be higher if the ECMO circuit, diffuser, oxygenator has worked effectively. So the SVO2 becomes the SaO2. It continues to be returned to the body, providing oxygen and CO2 at lower levels to the body. Cardiac output is typically 5 litres per minute in totality. So the SaO2 is determined by the total flow of oxygenated blood, and the PaCO2 is determined by the gas flow through the exchanger. Low saturation is caused by, first of all, recirculation, meaning that blood which has been saturated is being sucked back into the cannula, which is accessing it. So there's mixing. The cardiac output is basically the same. The ECMO output is basically the same. It's approximately 5 litres per minute in combination. It can also be caused by a high cardiac output. I mean, the cardiac output in total is 10 litres per minute. However, the ECMO circuit is now 5 litres per minute. So as a consequence of this combination, the patient's own intrinsic cardiac output and the ECMO cardiac output in combination, this can affect the saturation. Because you've got the low SVO2 plus 5 litres per minute, and then in total, you've got the cardiac output, patient's intrinsic cardiac output being added, which makes 10 litres per minute. Again, the SaO2 is the total flow for oxygenated blood. The PaCO2 is reflected by the gas flow through the exchanger. It can also be malfunction. So if your gas exchanger is malfunctioning, you're going to get a low saturation. High CO2 can be the result of gas exchanger malfunction again. Or you've got the incorrect gas flow. It's too low. Remembering that oxygen flow into the exchanger will increase if you've got a high flow CO2 removal, or it won't allow excretion effectively if it's too low. So incorrect gas flow or gas malfunction in the exchanger. Low CO2. This can be a sign that you've got an incorrect gas flow, as I mentioned. You've got too much oxygen going into the gas exchanger, which is increasing CO2 removal. Yes, increasing oxygen delivery, which is good. Or it could actually be a sign that your lung function is improving. Okay, thanks everybody. That's the end of part 4 of Dr. Manny's V-V ECMO Learn shops. If you found this of any benefit, please recommend it to your colleagues. If you want to subscribe, please do. If you've got any questions about anything in any of the Learn shops, please let me know. And most importantly, look at part 5, 6, 7, 8 and 9 of the V-V ECMO Learn shops and any of the other Learn shops on YouTube. See you next time.